Welcome to this panel titled Polio Eradication, Introducing IPV and Strengthening Routine Immunization. I'm Victor Zonana, a principal in the firm of Global Health Strategies. Today's panel is hosted by Global Health Strategies Initiative and the Global Polio Eradication Initiative. GPEI, of course, is made up of WHO, UNICEF, the Centers for Disease Control and Prevention, Rotary International, and it is supported by the Bill and Melinda Gates Foundation. I want to thank all of our distinguished panelists for being here, audience members for joining us, and of course, our hosts at the World Health Summit. Today's panel is taking place at a pivotal moment in polio eradication. Cases in endemic countries are now down 40% year over year. We still have troublesome outbreaks, most recently, of course, in Syria. But right now, the polio program is embarking on the most ambitious vaccine introduction in history. The rollout of IPV in 124 countries by the end of 2015. You're going to hear a lot more about that momentarily. Germany, of course, has been a key supporter of the polio eradication program, recently pledging 105 million euros over the next 5 years to support eradication. It goes without saying that eradication of polio will take huge global collaboration, and I think the people who are assembled today are representative of what needs to happen. It's now my honor and pleasure to turn over the moderation to Dr. Elizabeth Miller, the chair of WHO's SAGE Polio Working Group and a consultant epidemiologist in Public Health England. Dr. Miller.
I trust this is working. Can people hear? Despite our rather relaxed appearance as though we're sitting around a coffee table in our lounge, as Victor said, the world is embarking on what is going to be one of the most potentially rewarding but also challenging initiatives in global public health, and specifically in the Global Polio Eradication Initiative. And we have a panel of distinguished speakers, and as Victor has said, the big push, which many will be talking about, is the introduction of inactivated polio vaccine in 124 countries that up to now have exclusively used the OPV, or the oral polio vaccine. Now, in order to understand why IPV is being introduced and what the big initiative is that is part of this endgame strategy, a new document released by the GPEI, Global Polio Eradication Initiative, in May 2013 this year. For those that are not familiar with the sort of science behind polio, I need to just give a few outline facts. Now, polio, as you know, is a virus that is spread fecal-orally. It comes in 3 strains, type 1, type 2, and type 3. They can circulate independently of each other. Each has the capacity to produce the devastating effects that people are familiar with, acute flaccid paralysis, meningitis. Each has a slightly different profile in terms of how many infections they cause to how many paralytic cases. But a lot of people don't realize that the world has already achieved eradication of wild type 2 virus. For the last decade, every country in the world has succeeded in eradicating transmission of wild type 2. And just hold that fact for a minute. Type 1 and type 3 still circulate, and haven't been interrupted so far in 3 continuing endemic countries, which is Afghanistan, Pakistan, and Nigeria, although there has been a 40% reduction in cases in these 3 endemic countries in the last year. Now, the tools that the world has to control and eradicate polio are 2 vaccines. The oral polio vaccine contains live and attenuated strains of type 1, 2, and 3. And this is the vaccine that the world has relied upon to achieve global eradication of polio. It is very easy to administer. I doubt whether there's anybody in this room who's not had drops of oral polio vaccine. So we call this TOPV, trivalent oral polio vaccine. So we haven't had a wild type 2 for a long time now. So why are we still including type 2 in the vaccine? And that is a very good question that was posed to WHO about 3 years ago on the basis that the type 2 in the oral polio vaccine can very occasionally, probably about 1 in 2 to 3 million doses, itself cause paralysis, and that's called vaccine-associated paralytic polio, VAP. And quite clearly, even though it is a very, very rare side effect, since there's no wild type 2 to prevent, it was considered that maybe now is the time to stop using type 2. Also, poliovirus from the vaccine can sustain transmission at a population level if immunity isn't very high and give rise to what's called circulating vaccine-derived polio, CVDPVs. And again, these are more likely associated with type 2. So the WHO and the World Health Assembly agreed that as a first step towards the global eradication of polio, type 3 would be taken out of the vaccine, substituted with a bivalent vaccine, and thereby the first stage of global eradication of at least type 2 would be certified. Now, the second vaccine that we have available is the inactivated polio vaccine, which needs to be injected, contains killed viruses against all 3 strains. And the concern has been that when global use of the trivalent vaccine stops, the bivalent vaccine is only producing immunity to types 1 and 3. And therefore, the WHO, through its SAGE committee, recommended that in order to achieve a level of baseline immunity in all countries after the switch from trivalent to bivalent, that at least 1 dose of inactivated polio vaccine should be introduced in all countries that have not so far using it. That is a huge logistic challenge, and my panel here will be going through some of the financial, manufacturing, operational issues behind that decision. It will provide protection for those populations who are no longer using the trivalent, and I say it is a highly ambitious development in the program. So first I'd like to introduce Dr. Nina Schwalbe, who is, I don't know your official title, your Garvey, who is the Managing Director of the Global Alliance on Vaccines and Immunization, which is a public-private partnership that has played an absolutely key role in the introduction of many new vaccines in low and middle-income countries, and will be leading the introduction of IPV in the 124 countries that are so far not using it. The target date for this introduction is 2015. We're talking about something really round the corner. So, Nina, if you could.
Thank you, Liz. I'm pleased to be here today and thank the organizers for including Gavi in this. As Liz mentioned, Gavi is a public-private partnership focused on saving children's lives and improving people's health through immunization. And we have a couple of strategic goals that we use to try to achieve this. We introduce new vaccines. We try and ensure that the health systems are stronger so that they can support the introduction of new vaccines. We think about the sustainability of immunization programs, and we also work with the manufacturers to make sure that ultimately the vaccines are affordable and accessible to countries. So when, what Liz called the endgame strategy started to evolve, it became clear to the Gavi board that Gavi engagement was critical. And a couple of reasons why, and that's what I'll talk to you about today. One is the intersection between the endgame and strengthening routine immunization. In 1988, when the World Health Assembly committed to polio eradication, it focused also on the role of improving routine immunization programs to achieve eradication. And I think as we moved over the years, 1988 was a long time ago, as we moved over the years of trying to deal with this epidemic, and Liz gave a wonderful explanation of what is in fact incredibly complicated from a scientific point of view, and we're really learning as we go about what's the interaction between the three types, how does the oral vaccine work, and what's the potential interplay and role of the inactivated polio vaccine. We focused a lot on campaigns, and I think now we're seeing that in order for really countries to sustain the efforts, they have to have strong routine programs. And how do we see that? One of the ways that we see that is the countries that are still struggling with eradication of polio or making themselves polio-free are the same countries that are struggling with routine immunization. Nigeria, Afghanistan, until recently India, which is now improving its immunization systems and also now improving, has been polio-free, I believe, for 3 years. Is that correct? Yeah. So almost 3 years. So then the question is, how do we ensure that the systems are in place and strong enough? There's a lot that polio can contribute to knowledge in this area. The work that they've done on microplanning and figuring out who's unimmunized will be an incredible boost also to routine immunization. The fact that they know household surveys, the idea of bringing the polio knowledge into the routine, we also believe has a tremendous possibility to strengthen how we're delivering routine. Right now, still globally, 1 in 5 children do not receive vaccinations, and we believe that by bringing polio together with the routine group, this will help to make sure that every child everywhere gets vaccinated. So again, why Gavi? Well, one of the reasons why is we focus on strengthening routine systems so that every child everywhere gets vaccination. The second is Gavi's unique role in introducing new vaccines. Gavi was set up to help make sure that technologies that were introduced in higher income countries also reached kids in lower income countries. The irony was that with vaccines like hepatitis B, that protects against liver cancer, or Haemophilus influenza, which is a leading cause of death of kids in developing countries. Those vaccines were available to kids in Germany and the US and in the UK, but they weren't available to the kids who were dying from these diseases. So Gavi was set up in 2000 to help make sure that kids everywhere, and particularly in poor countries, Gavi's focus is on the 73 lowest income countries, got access to these vaccines. And so far, Gavi's been quite successful in trying to accelerate timelines. Now the 73 poorest countries of the world as of next year, the last being Southern Sudan, which is in fact to some extent a new country on its own, will have introduced a pentavalent vaccine against hepatitis B, Haemophilus influenza, and DPT. But it's also working now to introduce other new vaccines. The two most recent examples, or actually the three most recent examples, are a pneumococcal vaccine against pneumonia, rotavirus vaccine against diarrheal disease, a killer form of diarrheal disease, and human papillomavirus against cervical cancer, all very new vaccines in higher income countries, and Gavi's accelerating these use. We will have facilitated in a 5-year period over 100 introductions of these vaccines in 73 countries. Now, I want you to compare that scale to what we're talking about in terms of polio, and here's where we come across our first challenge. I wrote down these numbers because, so 36, in terms of rotavirus vaccine, a new vaccine, we will have introduced facilitated with countries, working together with countries, 36 introductions by 2015. In a 5-year period, 36 introductions. Pneumococcal vaccine, 57 introductions in a 5-year period. What we're talking about with polio is an unprecedented scale of introduction of a new vaccine in a 2-year period. Now, the good news and the reason why we're optimistic is, if you look in sort of the history of vaccine development, we had very few new vaccine introductions until the year 2000. Starting in 2000, we started to introduce hepatitis B and Hib in the developing country settings. And now, as I said, 73 countries, all the poorest countries in the world, have introduced these new vaccines. And now they're adding more new vaccines: pneumococcal vaccine, rotavirus vaccine, rubella vaccine. We'll soon to introduce Japanese encephalitis vaccine. So there's now a taste and an understanding of exactly what it takes to introduce a new vaccine. And many countries also, Ghana is a great example, have introduced vaccines simultaneously. They've said, let's take the opportunity of our training of health workers when we introduce one vaccine to introduce another. Because basically it's the same training module, it's the same people, it's the same populations, same parents that we need to talk to about introduction. So we have experience. And what we're trying to do as a global community now is build on this experience of introduction to also add IPV. I want to conclude by what we think is going to be needed to make sure that this is a successful introduction period, and what we're working on together with the partners at GPEI, the SAGE industry, and of course, most importantly, our partner countries. Gavi works through its partner countries to make sure that we're doing our introductions in a way that fits their needs, that they have the systems in place. So one thing is to ensure that both partners and countries are well informed in the decision-making and planning. It's a very fast-moving game. The end game is very fast-moving, and everybody has to be kept informed. We're working with industry also to make sure that supply will be reliable, affordable, and ready for introduction. That countries have the effective cold chain systems that they need in place to add a new vaccine. Systems were set up for the introduction of a certain number of vaccines, and when you add another one, you need to make sure that the fridges are in place to make sure that those are delivered reliably down the system to the child at the end of the line of service delivery. That health workers are adequately trained, both in terms of the technical knowledge, but also in terms of understanding what parents' fears and misunderstandings may be, so they can work to advocate with those parents and make sure that everybody is well informed about what this means and why we're doing it. And also mobilizing communities. That has been an area, in the past, a lot of vaccination has been very sort of system-driven, or what we call supply-driven, so health systems-driven. And if we're going to achieve this unprecedented rollout and get coverage to where it needs to be, we need to make sure that communities are also engaged and understand and are champions for what we're trying to bring forward. So I'll leave it at that. Thank you, Liz. Thanks very much.
We'll have open discussions at the end. But our next speaker is... Our next speaker is Dr. Jarbas Barbarossa, Secretary of Health Surveillance, Brazil Ministry of Health. Now, IPV has recently been introduced into Brazil, and we're going to hear something about the challenges and experience of a country that, up until recently, had been traditionally an OPV-only using country.
Thank you very much. Thank you very much. First of all, I want to thank the organizer for inviting Brazil to share some experience for the very recent introduction of IPV in Brazil. I have 2 or 3 slides to present, but I don't think if they are available.
Should be. Click.
Okay. Talking about the replacement of OPV in Brazil is a tremendous history in public health, because the OPV is so popular in Brazil that you can see this small superhero in the bottom of the slide. It was developed by in an advertisement campaign in the middle of the 80s, and it's called the Zé Gotinha. It's like Joe Little Drop. And it's so popular in Brazil that even in the end of the use of OPV now, Zegotinha became the symbol, the icon for the national immunization program in Brazil because it's very, very popular in Brazil. In this slide, we have the summary of the fight against polio in Brazil. Brazil introduced the strategy of campaigns in 1980. At that time, there was a huge debate in the countries. Some public health workers thought at that time that the campaign could jeopardize the routine vaccine, and now we can see that nothing of this happened. In fact, we had a lot of synergistic cooperation between the two national immunization days that we have annually in Brazil since 1980, and they also improved the routine immunization strategy, as the previous speaker also thought that is being done in some countries in Africa and Asia. Brazil eliminated polio in 1989. This was the last case that we had in Brazil, but we still have the strategy of routine immunization and national immunization days until 2011. In 2011, we decided to start the replacement of the vaccine. OPV was a very important tool to achieve elimination because, first of all, it is easy to administrate. In Brazil now, we have around 35,000 vaccination rooms in the health centers. But in the National Immunization Day, we have 110,000 vaccination rooms in churches, in NGOs, in community facilities, because it's very, very easy to use. And it is also very useful because in slums, in very poor communities that lack sanitary good conditions, the vaccine disseminates in the environment, and it vaccinates, and the children that didn't get the vaccine also become vaccinated. But 2011, we started the discussion with the scientific societies, the states and municipalities. Brazil is a federal state. We have a federal republic. We have 27 states and 5,600 municipalities. So we started a lot of technical and political discussions that it was time to start the replacement. OPV is safe. I think that's a safe vaccine. But we have, since 1989 to 2011, when the surveillance system on adverse related events is well established, we have around 48 cases of VAP. So we think that 24 years since the last case, each case that we have of VAP can jeopardize not only the polio vaccination, but the national program as a whole. So we started the discussion in 2011. We had a lot of support from the scientific societies, the public health workers, but also the families were informed why we were doing this process. And we started using the IPV for the first and the second dose when the risk of VAP is higher. When you are using the OPV, the risk is much, much higher for VAP in the first and the second doses. And we are still using the OPV for the third doses and the first booster doses. So this scheme will remain until 2017, when we are monitoring the global situation, but maybe there we will reach the global elimination so we can complete the process. I think that the vaccination in Brazil is a success because it's not only a matter related to the national health system. Each year, we have 2 weeks that we in June and August, we have a very intensive social mobilization with public advertisement campaigns in media, TVs, radio, press conferences with the ministers, the governors of state. and we have a lot of support for the community. This is the advertisement, one advertisement for this year week. And I think that another challenge that we have in Brazil is how we can reach everybody, not only the big cities, but in the slums, people that live in small villages in the Amazon jungle and so on. So far, we have used around 3.7 million doses of IPV, and I think that there is a lot of support. I think that children are not so happy because we are replacing a drop for a shot, but I think that the families understood, the Ministry of Health. We took around 6 months releasing, launching notes with press conferences and making all the information available to the families why we are doing the replacement. So we had no complaints or no, I think that misunderstanding about the reason, and people are getting vaccinated in the same coverage level that we have using only OPV. So I think that is maybe a very important thing to explain to the physicians, the pediatricians, public health workers why the reasons that you need to replace. And I think that Brazil probably will be an example for the countries in Latin America. In Latin America and the Caribbean, I think that we will have a problem related with the affordability of the vaccine. We are replacing one vaccine that costs around 50, 60 cents by a vaccine that costs $2.5 each dose. So for Brazil, maybe it's not a big problem, but in some countries in Latin America and the Caribbean, this can be a problem. Latin America and Caribbean, we have a very particular situation because we have only, I think, that 5 countries or less that are eligible to receive donation. But we have many countries in Latin America and the Caribbean that they are not behind the poverty line established by the international economic organizations, but they are poor countries. They are poor countries because they cannot afford new vaccines for the whole population. So I think that this is one thing that we need to discuss. In the Americas, we have a mechanism to a common purchase mechanism called the revolving fund, and the countries in the Americas, I think that this will be a very important issue to guarantee the replacement that every country needs to make. So this is the very recent experience in Brazil that we have, and I think that's very good to be here and to share with you this history. Thank you.
Thank you, Dr. Barbarossa. I think that presentation gives you an idea of the scope behind the initiative of, in Brazil's case, of replacing some OPV doses with IPV. And that decision was taken independently of the move to the switch from TOPV to BOPV. And you've decided to put 2 doses in at the early slot in order to get the benefit from reduction in VAP. Many of the other countries, though, TOPV until elimination or till the switch is going to be given the same as before. It's not replacing a dose of TOPV or BOPV with a dose of IPV. It is an additional dose. And I think that's an important concept. The oral polio vaccine provides one huge advantage that the inactivated one doesn't, and that it prevents children transmitting in the event of being exposed to wild or vaccine-derived strains. And in some parts of the world, that is still the key advantage for having OPV. And you've got a mixed schedule, so in fact you get the benefits of both IPV and OPV. But for the remaining 124 countries that have not used IPV, this is an additional dose to their existing OPV-based program. It's now my pleasure to introduce somebody from India, and India has made a huge stride in the last few years, Dr. Vijay Yawali. Up until a few years ago, I think the GPEI thought that interruption of wild poliovirus transmission might not be possible in India, not because they couldn't deliver the oral polio vaccine. They delivered it many, many times over. The program was superb, but there was a lot of competition from gut pathogens, which meant that for each dose of oral polio vaccine given, there was less take than in some other countries. So it really was a huge challenge for India to be able to mobilize its OPV delivery systems to get sufficient high uptake, sufficient number of doses into each child to interrupt transmission. And that indeed was achieved 3 years ago for type 1 and type 3. And India is going to be one of the leading countries in introducing this additional dose of IPV into its program. And ask Dr. Iwale to take us through the plans and the experience.
Well, good afternoon, and thanks organizers for giving me this opportunity to be here amongst the luminaries discussing this Global Polio Eradication Initiative. This is what we saw in 2011. This was the last case of wild polio virus that was recorded in India, Ruksar, from one of the states of India. India has had a very long journey from 1995. 95, we embarked on this national immunization drives using the TOPV. Then we set up, it was a challenging journey. We set up India Expert Advisory Group, which from time to time evaluated the progress of this initiative, suggested tactics to modify the strategy. We realized that the 2 rounds that we were doing in the beginning were perhaps inadequate. We moved up to 4 rounds per year. Then we moved out from the health service facility to house campaign. We had a lot of social mobilization. We involved communities, religious leaders, universities, and there's been a great public-private partnership in India. The leadership has been great. There has been a tremendous political support. We have spent almost $2 billion in this polio control program. And luckily, today we are in a situation, we are almost completing 3 years of no disease because of wild polio virus. But then India is facing a challenge of maintaining this status. All of us are aware that there are countries where the wild circulation is still not interrupted. They're just across the border. There is a risk of importation. And as I brought out by the chair and the other speakers, there is a risk of disease caused by the vaccine virus itself. We see about 100 to 200 cases of VAP every year in India. The burden was not recognized in the beginning to begin with. Maybe the wild virus load was too huge to make a notice of this burden. And since last, say, 7-8 years, we have also started seeing the vaccine-derived poliovirus disease. We have had about 37, maybe 38 now, as on today, cases of VDPV. And most of the disease caused by this vaccine-derived poliovirus has been because of type 2. We have not seen type 2 wild virus since 1999. So it's high time that we lock in the benefits that we have accrued out of using this oral polio vaccine. We need to safeguard our population against this VDPV and VAP. So in short, the oral vaccine has to be phased out. And as, given the directive and the guidance by the Global Polio Eradication Initiative, this is going to happen. We're going to switch over from trivalent OPV to bivalent under the cover of IPV. This cover of IPV is also extremely important so that we maintain the high population immunity that we have achieved. And as I said before, these 15 years have been really a challenging task. Each and every part of the community was involved. We knocked at each door so that our coverage went up. We also cannot forget that the improvement in the routine immunization was also equally important in, overcoming this challenge of vaccination failure. We were plagued with both failure of the vaccine because of the high incidence of other wild pathogens preventing the appropriate take of oral polio vaccine, but there was vaccination failure as well. So we scaled up our routine immunization, and Global Polio Eradication Initiative and this project has really helped us scale up our routine immunization as well. But still, it is far from the optimal. Today we have national coverage of about 60-61% with DPT3. And with the proposed plan of introducing one injectable polio at DPT3 contact, we need to be really worried about this 61% coverage. But yes, now is the time when our surveillance is at peak. We are mentally prepared. We have all the inputs. There's a lot of social mobilization. There is a lot of political commitment. There's a lot of involvement of other NGOs. And this is the right time we could do it and scale it up further. The other advantage that we have had out of this project is, we realize there are a lot of communities or migrant children or population for whom the oral polio drops was the only contact with the health facility. And this opportunity was utilized to deliver other preventive tools, other health measures. The NPSP, National Polio Surveillance Project of India, also has been helping us in surveillance for another disease called measles. And I'm sure that would go a long way when we embark on measles control or measles elimination program. We have also started delivering maternal and child health services through this project. And time has come to reap benefits out of this well-established network and the public-private partnership that we have established in India. Introducing IPV is going to be a challenging task in terms of coverage, in terms of acceptance. As like in Brazil, though OPV was used, in India also we're going to face the same situation, that people are going to question us, where all years we have been talking about OPV and highlighting OPV as the only tool to eradicate polio. Now we're going to introduce something which is inactivated, injectable. The things are going to be a little different than the oral polio. But yes, there is a lot of political will and determination, and I'm sure this experience and the network that we have established would go a long way in introducing this injectable polio in India. I'm very confident that January 2014, when we see no polio disease because of wild virus for 3 years, we would obtain certification of polio-free country along with the Southeast Asian region. And we are geared up to take up this introduction of IPV and then switch over from TOP to BOPV.
Thank you very much, Dr. Yawali. I'm sure the eyes of the world are going to be on India, because this is going to be a really great test of the system. Also, the injectable dose that you will be given will, of course, boost immunity to types 1 and 3, which will still be given in the vaccine. So there are considerable advantages other than reducing the risk of VAP and CVDPVs. And of course, this changeover, or it's not changeover, this replacement of the trivalent vaccine with the bivalent vaccine and the introduction of at least a single dose of IPV about 6 months before that switch is predicated on the assumption that there will be cooperation from manufacturers in hugely scaling up their IPV production and at the same time coordinating the switch from trivalent to bivalent production. That is not a trivial task, and it needs buy-in not only from the manufacturers, but the global community, Gavi, WHO. I think everybody working together to trust each other that we're all on the same trajectory. Because when TOPV is replaced by BOPV, this has to happen in all countries at the same time. Some may decide to go a bit earlier, but there can be no country that decides to continue using the trivalent vaccine and continuing to pour OPV type 2 into the environment. So looking forward to Dr. Weibacher, who is CEO of Sanofi, who's going to tell us your plans for assisting the global community in this endeavor.
Well, thank you very much. It will require not only the cooperation of industry, but really everybody working together. Already a huge amount of money has been spent on getting us this far. The end game is expected to cost over $5 billion. But for those of us who were at the Gavi annual meeting in Tanzania last December, Hans Rosling did one of his usual terrific presentations. He demonstrated essentially that where you can reduce child mortality, you will reduce family size. And when you reduce family size, you dramatically improve economic growth. So it is clearly a program that is essential from a public health point of view, but there is also a significant return if we can do this, so that although there's an investment, this actually has a big impact on the economy. Now, we are talking about moving from OPV to IPV, and there are a number of factors to consider. First of all, and this is why I think this forum is so important, there are people who ask the question, well, if we've got this far with OPV, why do we need to go on with IPV? There are a number of logistical aspects to this. If you're going to give an IPV vaccine, this has to be kept refrigerated, and this provides often a lot of difficulty, especially in what we call the last mile issue of vaccination. I co-chair with Bill Gates a consortium of pharma companies trying to actually fight neglected diseases, and we just actually had a meeting last week, and we noted that actually we now have all companies fully supplying medicines. The only issue that is really left is now on distribution, and in fact the distribution issues were a highlight at the Gavi conference last year. So within this roundtable, some of the things that the industry is doing is working together on the vaccine piece, for example, to try to say, well, how long can a vaccine really stay out of the cold chain? Because these are very practical problems that you can keep a vaccine in the fridge up until the last minute, but I can tell you, having visited Chad last year under 50 degrees Celsius heat, when you've got just a table and you've got people under a mango tree somewhere, how long can you keep that vaccine out and have it actually still effective? And so we've been working on how do we actually allow for the vaccine to be out of the cold chain for longer, and can we actually even develop technologies? We have, as a company, a partnership with MIT in trying to use new propulsion technologies so that the vaccine could actually not even be in the cold chain at all. Now, also there is a question of cost, and here we're vaccinating on a huge scale. And so one of the things that has been done, if we look at OPV, is to really scale up. So our company, for example, has been producing the OPV vaccine for over 20 years. We have produced in that time 5 billion doses of OPV. Largely in partnership with the Rotary International, with UNICEF, with Gavi, with the Bill and Melinda Gates Foundation. But as a result of that scale up, we've been able to dramatically reduce the cost of OPV. And today, if you actually look at the overall cost of this eradication program, only 6% is actually related to the vaccine. Now, the IPV is different because the IPV is a different type of vaccine. We're talking about a biological product. You have to have sterile fill and finish technologies, which are quite expensive. Now, our company as well has been involved really from working with Jonas Salk in the 1950s. A Canadian company called Connaught was originally involved in trying to facilitate the production of the Salk vaccine. Connaught is now part of Sanofi Pasteur. We have been building up the volumes over time. We enhanced the Salk vaccine with Charles Mérieux in 1975. And again, the Mérieux vaccine business is now part of Sanofi Pasteur. And really, we have been scaling up over the years. Probably as a company, if we look back, we scaled up way too early. But today, we are sitting on the biggest capacity for manufacturing IPV. And we have already produced over 800 million IPV-containing vaccines over the years. As Dr. Miller noted, there are 3 subtypes. We actually have a vaccine that can address all of these different subtypes. Now, the next stage we have to go to is to say, how do we really roll this out? First is the IPV vaccine itself with this volume. the more that we can get precision around how many doses we need, the more we can actually create the investment. We've spent over $150 million already on building up capacity. And we have been working with Gavi, with the Gates Foundation, with UNICEF, with Rotary to really get an idea about how many IPV doses are going to be needed. And the whole industry will need this because in order to be able to invest, you need to be able to actually produce. And it's not just a question of whether you're going to get a return on that investment. A vaccine manufacturing facility has to produce or it can't continue. You can't have people come in and come out. There's a high degree of know-how goes into this. The vaccine facility has to actually operate to be effective. So you can't even have a facility continue if you don't have the doses. So this is extremely important. That's why the partnership is important. One of the other things that we did is we, about 4 years ago, I acquired a company through Sanofi called Shanta. Shanta is a biotechnology company based in Hyderabad in India. It was originally designed to make the hepatitis B vaccine available for the masses. We obviously want to build the IPV vaccine into the normal series of pediatric vaccines, which would be the way to really keep this going over time. There are 110 million babies born every year. 10 million of those are born in North America, Europe, and Japan. 100 million outside those areas. Now, the only way that you're really going to be able to provide this pediatric series of vaccines, including IPV, is if you were to have a high-quality, low-cost vaccine manufacturing facility, which we've done with Shanta. Now, Shanta had done the hepatitis B, but couldn't really scale up the Shan 5 pentavalent vaccine. So having acquired Shanta, we have spent the last 3 years completely redeveloping this. We've spent another $150 million on redeveloping this vaccine. We expect to have WHO pre-qualification in the spring. That will then allow us to marry that Shan 5 with an IPV vaccine to create a Shan 6 vaccine. And the obvious benefit to this is that despite the fact that we have invested all this money, by being able to improve the yields, we believe that we'll be able to still sell the vaccine at the same price that Shanta did before all the investment was undertaken. So we also in Shanta have an HPV, second generation HPV vaccine under development, and a rotavirus, because in addition to this, and that's why I take the point that when you actually start vaccinating, you create a point of health, and therefore you can use those points of health to actually expand vaccination programs. So for us, we have been in the fight with partners for decades. We have manufactured 5 billion doses for OPV. We've manufactured hundreds of millions of doses for the IPV. Expect to be able to do the same. Other companies are stepping up. We are trying to redevelop vaccines so that we can minimize the cold chain issues through our initiatives with neglected diseases. We're actually working with companies like DHL and FedEx to actually deal with the last mile problem in distribution. But I think we're taking a public health point of view. This isn't just about manufacturing a vaccine. It is very much trying to work with partners on the scale up, on reducing the cost, on dealing with the logistical problem, so that ultimately children get vaccinated and children are protected against disease. So thanks very much.
As you mentioned the important question of cost, because many countries who will be introducing a single dose of IPV, paying $2.50 is outside the range. The long-term goal is to make manufacturing initiatives, adjuvanted vaccine, Sabin strain vaccines that can be made in a number of locations, possibly intradermal use, which will drive the price down to less than the 50 cents a dose margin. That is the longer-term strategy post-2018. But for the shorter term, over the next 5 years, then this is where Gavi is and UNICEF played a very active role in terms of making an available a vaccine to countries that really for the $2 a dose or $3 a dose will be out of out of the range. I don't know if Nina wants to come back on that, talk a little bit about the UNICEF tender that has gone out, because the other thing that you mentioned was having a clear idea of what the market is out there. And I think when SAGE made its recommendation a year ago, that really allowed manufacturers to understand the scope of the demand for IPV over the next 5 years. And to that end, a tender has gone out for the IPV that will support the switch from TOPV to BOPV. And I don't know if you'd like to talk about that.
So UNICEF has issued a tender, which I think is scheduled to close in 4 weeks, if I'm not correct. It was issued about 2 weeks ago, through their normal tender processes to really begin this switch. The Gavi board will also make a critical decision in November of this year, which is whether or not it will engage. All signs are moving in that direction, but the board will take a considered decision on its engagement in the introduction of IPV. In any case, as we said, the collaboration with GPEI will have to be strong because we're all about immunization and we're all about strengthening health systems. I mean, on the pricing that you mentioned, actually that's even a little bit higher, Liz, than is being quoted in the public domain. So 250 and 3 is higher. It's more around between 1 and 150, yeah, 175.
Prior to the initiatives to drive down the cost, because although the long-term strategy is to have a much cheaper, more affordable product, there have been initiatives in the shorter term to cover this 5-year period that would have driven it down from what used to be the market price to hopefully within a range that it is at least subsidizable in the short term.
That's absolutely correct.
I mean, one of the things that clearly the industry has been practicing and which will be needed for IPV is tiered pricing. So there's a massive investment, and biological manufacturing is probably the most sophisticated form of manufacturing that we do. It is far costlier to do biological manufacturing than, for instance, to manufacture tablets. Largely because in the syringe, the product has to be perfectly sterile. If you swallow a pill, you know, your digestive system will protect you from certain impurities. If you're going to inject someone, you bypass that whole system. So that the vaccine literally has to be perfect over hundreds of millions of doses. The second is that it's extremely important to have a sustainable supply of vaccine, because Gavi and UNICEF can't really launch these campaigns, countries can't launch these campaigns unless they know that every year all of these vaccines are going to come along. And there's a constant reinvestment needed to be able to maintain sterile manufacturing and fill and finish within the manufacturing process. So the way that has been done is to try to match the price of a vaccine with an ability to pay. So that if we can charge a higher price from some higher income countries, we can offset, therefore, the price of the investment and offer to the lowest income countries something that is really at a no profit, no loss basis. Now, what we have seen with other areas is it is typically unadvisable to go below no profit, no loss, because if it becomes a donation, then the donations have tended to be, when we look at the last 10 years of experience, not necessarily sustainable. So the model is essentially this no profit, no loss, but obviously you have a no profit or no loss on a marginal cost basis and a fixed cost basis. And to be able to recover the fixed cost, that's why the tiered pricing has been done. And you will see now countries and companies starting to invest in this biological manufacturing. And that's why the tenders are important. But, you know, companies won't really invest if they're not really sure that the volumes are going to be there. And we all have to, you know, to put the real problems on the table. It hasn't been necessarily an enthusiastic response by all 124 countries to say we want to go to IPV. That is starting to change. And, you know, Sanofi Pasteur made this investment, but not everybody has made this investment, largely because there's been a doubt about how fast is IPV really going to be utilized. So this is where these partnerships are all important, where all of the members of the public health community, as well as organizations like Gavi and the industry, all have to be absolutely aligned. And if we are, then we can solve the distribution issues, we can solve the pricing issues, but it's going to be extremely important that there's enough supply. And I think we will get there, but the more we have some level of predictability, the more other companies will enter this area.
I guess the response has been quite positive and encouraging. In India, for example, there are about 5 companies which have been identified to either manufacture the bulk or fill and finish. We have Serum Institute of India Limited, Panacea, Bharat Biotech. They are also working towards dose-pairing IPV and the Sabin IPV. And I guess this time I get you. I mean, I totally agree with you that there has to be some, assurance. Unless that comes, the companies are really not in a shape to give some commitment. But I think that difference is very much obvious this time, it seems.
There is a massive international effort underpinning the introduction of IPV and the switch of TOPV to BOPV. There's something called the Immunization Systems Management Group, which consists of WHO, Gavi, other partners, to really engage at an individual country level, rather than saying, well, do it if you like. This is a very important initiative and it has to work. That is fully recognized by WHO, and there are some really quite detailed work streams underpinning the introduction and allowing dialogue with countries. And I think, as you mentioned, people understanding what the switch is and what IPV will achieve is incredibly important. Now we have time for open discussion, but we have 2 interveners from the audience who'd like to make some brief comments or questions. So I'll call on first Dr. Marcus Cole, who's the Health Division Desk Officer for the Federal Ministry for Economic Cooperation and Development, who's going to talk a little bit about the commitment of the German government to this initiative.
Thank you very much for the kind introduction. First of all, I would like to thank the panelists for their interesting presentations, giving us such successful examples like Brazil or especially India, and also showing us the involvement of the private industry. About the German contribution, as most of you may know, polio eradication is a key, or in our wording, a light tower project of my ministry. And I don't think I have to explain the reasons of the importance of this unique project. As you already heard from you, Germany is involved in polio eradication since a long time, and quite recently, beginning this year, we actually announced that we plan to spend another 100 million for polio eradication, at least, plus 5 million for the security of health workers, which was actually an issue the last years, if you followed the news. Regarding the introduction of IPV, we wasn't actually involved in their operational, but of course on a higher level we discussed all the time. But our funds are channeled as part of our bilateral cooperation, and this is always aligned with the wishes of our partner countries, and therefore we have to examine how we can, or how this might play a role for IPV introduction in the future. But on an international level, actually we are a contributor to Gavi and to the Global Polio Eradication Initiative, and therefore we support the closer cooperation of these both organizations. Like we heard, it's really an important issue, and we have to actually establish this. We are actually certain that Gavi can have a significant role in polio eradication, especially because of its comparative advantages within the introduction of new vaccines, like you already presented, and also your experience with routine immunization, which is also essential for polio eradication. So I think you can be sure that Germany will remain engaged in the development of this cooperation between GPEI and Gavi within all relevant committees, also the Gavi board in Cambodia, and also the Polio Partners Group. Thank you very much.
Thank you very much. If those are interested in seeing actually where the Gavi donations come from, I did have a look at the website to see who the public and private donors are, and it really is incredibly impressive. Of course, there's a massive input from the Bill and Melinda Gates Foundation, but also from other partners, national governments, and of course Rotary International has played a huge part in the Global Polio Eradication Initiative, and Hildegard Dracino, National Advocacy Advisor for Rotary International, is going to give us a perspective on the role of civil society.
Thank you for having the chance to speak here. My name is Hildegard Dracino, and one aspect of the introduction of IPV that has not been mentioned is the critical role that civil society organizations like Rotary International can play in helping to raise public awareness and ensure public confidence in all of the countries where IPV will need to be introduced and embraced by both the medical community and the general public. This is a role we have played effectively throughout the history of polio eradication. For example, Rotarians played a key role in encouraging the adoption of strategies such as National Immunization Days. We continue to play a significant role in engaging a broad range of stakeholders in the remaining polio-affected countries to promote public confidence and support for polio eradication activities. There are Rotary clubs in nearly all of the countries where IPV will need to be introduced. Civil society organizations can help and should play a critical role in highlighting this issue and helping to ensure the efficient adoption of IPV. We wanted to draw the panel's attention to this very specific point. We can also play a key role as the constituents in these countries to ensure that our governments support the introduction of IPV and where and when possible to encourage the donor governments to provide the necessary resources. And I'm happy that Markus said some words about the German position. Rotarians look forward to supporting the successful introduction of IPV. Thank you.
Thank you very much. I think, we're getting an idea of the scope of this initiative. It's big, it's challenging, but the rewards are huge. It will be the first step to what ultimately will be the global eradication of types 1, 2, and 3. So I think we have time now to open it up to the audience for questions. If you come up to the microphone, perhaps say who you are. Well, that is no.
Hello, good afternoon. My name is Abakar Kurfi. I am from the National Health Insurance Scheme in Nigeria. I was also working for the USAID in the northern part of Nigeria as a vaccinator and also as a policy maker in polio vaccination specifically. So I'm actually very happy today because when I heard of this issue of IPV introduction, I was so glad because it will go a long way in overcoming the challenges that we face in in giving OPV in northern Nigeria. There is so much socio-cultural, religious, negativity surrounding OPVs. There is this belief that it's associated with family planning, associated with a lot of negatives that have been so much and put on an OPV vaccine. And that's why we have this massive rejection of vaccines in northern Nigeria. So I think the IPV coming at this particular moment is actually something that I know will go a long way in overcoming these socio-cultural, religious barriers that actually I know will go a long way in solving this problem. And then secondly, I know one of the challenges that we're going to face also is the issue of insecurity. In the northern part of Nigeria now, there is a very, very high incidence of insecurity, both religiously and also for the vaccinators themselves. So I'm happy when I had my German colleague here saying that there is some amount of money that is actually earmarked for security of vaccinators. That's something that's very critical, and I know that when you people are discussing the issue of how far you can go, you should actually put that into consideration. The other issue is the issue of sustainability. It's critical because we wouldn't want to see a situation whereby we start a very laudable program and then all of a sudden, because of one factor or the other, the nations begin to backslide and then we'll go back to the square zero. Nigeria is a classical case whereby we make so much progress and then all of a sudden you see ourselves sliding back to where we were before, even worse than where we are coming from. And the last point actually we should consider is the issue of cost. Cost is critical, mostly for Nigeria, whereby we are seen to be a middle-income nation, but in reality we're actually a low-income nation, because Nigeria is actually two countries in one. There's the southern part of the country that is actually a very highly, very educated and a very rich part of the country. That's why they have very low incidence of polio. Of course, there's also the northern part of the country that's actually extremely poor. And that's where the incidence of actually this polio is mostly found. So I think it's critical that we should look at these factors in trying to decide whatever we decide. Thank you so much.
Thank you for your comments. I think they highlighted one issue, and that is in communication, in that there will still be oral polio vaccine given until eradication of types 1 and 3 is achieved. So while some of the problems associated with the trivalent vaccine, namely the propensity for type 2 to cause VAP, and you saw that in India it was 34 out of the 37 circulating strains and the predominant cause of VAP, that will clearly be removed, but the bivalent vaccine will still be the tool to achieve eradication. So I think that in introducing IPV, it is to help plug that susceptibility gap once the switch from TOPV to BOPV has taken place, because there may still be circulating vaccine-derived strains in the environment, at least for the first few years, and providing some level of immunity to the population against those with the inactivated vaccine is important, but it is an adjunct, it's a complement to the existing OPV-based eradication strategy, and I think that's quite important to make that clear.
Can I just actually add a comment first on the cost? It is true that the IPV will be more costly than the OPV, but I can tell you, having spent 20 years in the business of producing HIV medicines, when we tried to get HIV medicines for poorer countries, we struggled to get the cost down below $1 per day for months and years. Here, we're talking about a vaccine that is available in one shot for $1 to $2. So I think even in poor countries, when looking at budgets, this is significantly less than costs for treating so many other diseases, whether it's diabetes or epilepsy or HIV. All of these diseases equally exist in the poorest countries of the world. So I actually think this has been an enormous success over the years. And I really have to pay tribute to Rotary International in particular, because we today have the Gates Foundation and Gavi, but the organization that first took up the fight before anybody else was doing this was Rotary International. And by their action, they actually created a partnership with industry that allowed us to really drive down the cost of this. So, I think this is where these partnerships really help. I mean, this is actually quite a miracle that we can provide such a protective treatment at such a low cost. Now, I can tell you that when I talk to Bill Gates or I talk to Seth Berkley at Gavi, there is always a question of, how low can you get the cost? But let's keep this in perspective, that compared to a whole lot of other therapies, this is an amazing economic investment, both from a health point of view, but also in reducing the child mortality and encouraging growth.
If I may share, along with the cost, the other concern that we have in India particularly is coverage. We are a huge birth cohort. Almost 27 million babies are born every year. And we have about 9 million immunization sessions happening, some 25,000 cold chain points. I mean, one needs to look at all those logistics, and that's also going to be a challenging task when we talk of introducing even single dose of IPV. And as I alluded to before, acceptance by the community, even by the academy, because in India, we have NTAGI that makes policies for the National Immunization Program, and we have Indian Academy of Pediatrics. It's an organization of 22,000 members, and there are another 22,000 members who are not members of the association, but they look up to and follow what the recommendations are set out or sent out by the Indian Academy of Pediatrics. IAP for last maybe 3 years or so has been, ever since the vaccine was licensed in India, has been talking about minimum 2 or 3 doses of IPV. So there's going to be sort of inequity there also. So these are a few concerns which are really, at the back of our mind. But all said and done, this is the time when we need to overcome all this, and this is the optimum, I would say the best time to introduce and get along with the Polio Eradication Initiative, the 2 steps of introducing at least 1 dose of IPV and then switching over from TOPV to BOPV.
Can I just say that the introduction of IPV to support the switch from TOPV to BOPV is a risk mitigation strategy. It is not a tool for eradication. I think this is where the message has got to be absolutely clear.
I understand, but I mean, academy is still not clear what is going to happen after that.
Yes.
I mean, we are still open on that issue.
Okay. Oh, please.
Hello, I'm Dr. Salima Bhatia. I work with the Ministry of Health in India. I'm a consultant for the National Rural Health Mission. And while Sir has absolutely pointed out what are the major challenges, I just want to add one more challenge, and that is the training of ANMs. I mean, training of our health workers, which is going to be, and more than 5 lakh ASHAs that we have, more than 8 lakh ASHAs now. That is going to be a very big challenge for us, because till we actually go down to the last person, it's going to be very difficult to implement. Second important thing is that we think support from our funding agencies, partners, and others would also be important in terms of monitoring and surveillance, because these are the other 2 areas which might require more focus once we are introducing this. Thank you.
I want to make a brief comment about I think that we have a very particular situation, and I think that in public health, in elimination strategy, the first step and the last step are the most difficult that we have. Because we have different situations in the world. In some countries, we still have to make a lot of efforts to ensure that every child will receive the OPV. But in other countries, we are in developing countries like Brazil, we are already switching to the IPV. And I think that this is a problem that we need to face, and the message needs to be very clear. OPV is, I think, that the most important tool that we have to stop the transmission of polio. I think that it's very clear for us that now that in Brazil we are polio-free for 24 years now. In Brazil, in some countries in Latin America, in Dominican Republic, and other countries, we had I think that they thought that they don't need campaigns more, and they had outbreaks of polio virus vaccine-derived. So now the problem that we had in Brazil is how to explain because people in Brazil know that we owe the elimination to the OPV. In the first press conference that we had to present a new strategy, the journalists asked the minister, why do the Minister of Health wants to kill little Joy Drop, our hero that make it possible to eliminate polio in Brazil? So we spent almost 1 year explaining and holding some technical meetings to have a build consensus in the country. And the other thing is the cost thing. I think that we now have very important mechanisms in Gavi and other mechanisms that can ensure the vaccine to poor countries. Because if we are so close to elimination when we think that we are, in the next 3 or 4 years, maybe we will have the elimination. So the replacement of the vaccine is not a problem for the future. It's a problem for the present, because you need to have how many doses we will need in each year. So I think that's a lot of things that the global community, WHO, and the other agents need to start to discuss now with the countries.
I think that we have some positive lessons to learn actually from the rotavirus vaccine introduction, because when we introduced rotavirus vaccine, kids still are going to get severe diarrhea, and they're still going to die of severe diarrhea. So we had a challenge with the health workers. We were very worried about this in the beginning of the introduction, so that people didn't think this was the panacea, this was going to solve all of the problems, and no child was ever going to have diarrhea again or even die of diarrhea who'd received the rotavirus vaccine. So I want to put that in as a positive statement to say, that's been a case where we were extremely worried as a public health community. Now, the jury's not out. We've only introduced in 13 countries, and we have another 50 to go. But still, it does show that with the proper training and the time taken, and as you said, a year spent showing that you were going to kill that cute little cartoon character, that you can do it. But it takes effort, it takes financing, and it takes a really concerted strategy to make sure that you've covered that box.
Have we got some more questions from the floor? Yes, please.
Dr. Robert Sobag. In the history of medicine, the only case of eradication was smallpox. Smallpox was the human transmission. Polio is a little different. We're in front of a wild virus. Do you think the word eradication is a good one and not elimination? And I've seen that, Dr. Barbosa, you speak about elimination and not eradication. When you are in front of a wild virus, you have to maintain first immunization during long term, but also the risk of some people that will escape from the immunization, and you will have always a virus. It was not the case for smallpox. It's why I would prefer the word elimination and not eradication.
I mean, there is no more endemic circulation of wild type 2 in any country. So if you wanted to, say that there's been global eradication of wild type 2, clearly, while one is still pouring OPV2 type viruses into the community, there may also be wild type viruses held in laboratories. There are individuals who do excrete long-term immunocompromised. This is why the IPV risk mitigation strategy is necessary, because, as you point out, there are still potential sources of circulation, at least of vaccine-derived strains, after the cessation of immunization against them. So the first stage, and it is a phased withdrawal, is to stop using the OPV2 and go to a BOPV. And that is what the IPV introduction is, to mitigate against this risk of appearance of vaccine-type strains in the post-cessation era. And I think the concepts of, smallpox being applied to polio, you're quite right. Polio is a lot more complicated. And I wanted to thank the lady from India who mentioned the importance of surveillance, because as we've seen in countries like Israel, where you are using IPV, you can still have circulation unless you've really got good surveillance to interrupt transmission before you have any clinical cases. Then the post-eradication or post-elimination strategy is not going to work. So surveillance is equally important as the introduction of IPV, and until such time as we have demonstrated interruption of types 1 and 3 as well, maintaining high levels of coverage against all 3 viruses through OPV.
Victor Zanon again. Chris, you mentioned the potential for a 6-valent vaccine as both a cost measure as well as presumably a cold chain sparing measure. Can you and other panelists talk about the extent to which IPV will initially be delivered in combination and eventually be delivered in combination?
So we actually have a hexavalent that we've just had approved by the EMA and is about to be launched in the spring in Europe. The benefit, obviously, of combination vaccines is that you avoid, first of all, the number of jabs, so that somebody coming in who's made the effort to come to a vaccination center can be vaccinated against 6 diseases instead of 1. So we certainly see a higher level of vaccinations across a broad spectrum of diseases when we offer combinations, largely because we make it, first of all, easier for parents to actually do that. Typically, we're able to help on price on that. This is where the Shanta vaccination production facility is so important to us, because we can now get the cost down below where we're producing in Europe and be able to provide a vaccine that's affordable to the 27 million babies, for instance, in India, or the 16 million babies in China. And putting them all into one syringe is not as simple as it sounds. And there's an awful lot of know-how that is needed to occur. And that's really what Sanofi brought to Shanta when we acquired it, because you can acquire the plant and equipment and train people, but actually Shanta was unable to scale up in its first UNICEF tender, and that's why we had to redevelop entirely the vaccine. But personally, IPV is less than, I don't know. I mean, it's less. I don't even know how much we sell of it. It's pretty small. It's less than 1%. But for me, what was really interesting about Shanta is that you had an individual who'd been turned down by everybody to get the technology to create this hepatitis B vaccine. But by having done that, he was able to provide vaccination for 100 million people instead of the 100,000 people that were getting it earlier. And so our vision was, by acquiring Shanta, by transmitting the know-how, and now also by bringing and supplying an IPV that can be added to this newly redeveloped Shan 5 pentavalent, we can offer an affordable 6-valent, hexavalent vaccine. And here now, the dream is that every new baby that is born gets the regular series of vaccination and is protected very much as we see in Europe, US, and other countries, and at an affordable price. And again, you're talking about less than $10 for all six diseases, for example. So now the cold chain, it's helpful only in that once you've set up the cold chain, you've got the six vaccines being done at once, so you don't have to multiply that. The way we can get rid of the cold chain is, first of all, we have to do the stability testing. We've traditionally developed a vaccine for US and Europe, and there's cold chain everywhere. And so I can tell you, I run a 35 billion euro company. And so when I sat in Tanzania and listening to supply chain issues, it was at a level of detail that I'm not used to seeing, but it was an eye-opening experience to me about the real difficulties of some of these logistical aspects. So now we've gone back, and as companies, we are actually saying, well, let's take the vaccine, let's leave it out. You have to do all the clinical testing to see whether the vaccine's actually, the efficacy is affected if you leave it out, and can you leave it out for 1 hour? Can you leave it out for a day? Can you leave it out for 2 days? So there's actually quite a big investment has to go into that. And the longer term goal is there are some technologies that allow powders to behave like liquids with jet propulsion. And if you can keep the vaccine in a powder form without liquefying it, you no longer have the same sterility issues, you have no longer the same preservative issues. And then, we might be able to, in a 5 to 10 year time horizon, get away from the cold chain entirely.
I'd also like to comment, actually we had a brief discussion about this just starting the panel, about the hexavalent vaccine. And there are a couple of issues around the pertussis and the pertussis that's used in it, and what's the most effective pertussis vaccine to use in developing country settings. There's also some questions about the timeline and how soon this product would be available and how it would fit potentially into the end game strategy. And then I think it's just something that we need to recognize and talk about, as well as the cost issue, which is that and now speaking to some extent on behalf of colleagues at GPEI, because we've debated this a lot with the polio group, is not all countries use the pentavalent vaccine. Actually, we're in a situation where we have incredible uptake in the Gavi countries because of Gavi, and we have very high uptake in the high-income countries because they can afford it in their health systems. And to the colleague from Brazil's point, we have some countries in the middle income that are not using pentavalent because they actually can't afford it, so it's cheaper for them not to do it. So there are a lot of issues to work out. We have some time to do it, and we're positive that any innovation that will help kids get less jab, help increase uptake, is something that we're all committed to doing, but there's a little bit of devil in the detail. I also wanted to make one comment on the cold chain. I think that we're thinking really differently now about cold chain, which is very exciting. And it's sort of like when you just get married and you buy your first apartment and you think, oh, we'll only have one child. And so you buy that apartment for the first child, and then you're on your third child, and you think, geez, I wish we'd thought of that when we bought our apartment. And I think it's a similar, or moved into our apartment, it's a similar situation around vaccines. We had a very incremental approach to the cold chain. We had our cold chain, and then we say pentavalent's coming along, so we add for pentavalent. And one of the exciting things we're doing as a community now is saying, okay, we're going to add IPV, but then maybe we have hexa, and then maybe we have dengue, and maybe we have a TB vaccine. And how can we really think about a step change in the cold chain and its expandability, as opposed to thinking, well, next year we'll have this, and the year after. So I think there's a lot of exciting developments to watch in that field.
Yes, I'm afraid we must bring things to a close. We have used up the time. I'm very glad you said that about the hexavalent, because I also chair the SAGE working group on pertussis vaccines, and the issue of what is actually the best form of the pertussis component, not just for developing countries, but also for, we have seen some issues with resurgences which may be associated with the switch to acellular. So the prospect of hexavalent is some way down the line, and for the next 5 years we are looking for the current OPV using countries at the standalone IPV at a price that we trust will be very competitive. That said, I want to thank everybody for their attendance here. It is a very exciting initiative, and I think it's going to be watch this space over the next 2 years. Thank you.